Boleh saya disable waiting room, so dia akan masuk semua. Alright.
Okay.
You boleh komen kat sini je.
Bisa kita mula?
Boleh.
Assalamualaikum and a very good afternoon to all NAPD members and
Recording in progress.
and all the officers and specialists and the respected audience. Today we are lucky to have Associate Professor Dr. Adli from UKM. Associate Professor Dr. Adli is a senior clinical lecturer and consultant pediatric immunologist in Hospital Pakar Kanak-kanak. His clinical work focuses on care for patients with primary and secondary immunodysregulation disorder, autoimmune allergy diseases, and vaccinology. Besides being actively involved in academic teaching and clinical work in patient care and research, he is a prominent driving force in patient advocacy, both in the region and internationally. Dr. Adli was fundamental in the inception of Malaysia Patient Organisation for Primary Immunodeficiency. He is also one of the founders of Southeast Asia Primary Immunodeficiency Network of SEA-PID, a regional network of professionals involved in the care and research of primary immunodeficiencies. Today, we are lucky enough to have Associate Professor Dr. Adli to share his knowledge and insight on COVID-19 children based on his experience. With that, I would give the floor to Dr. Adli.
Okay, Assalamualaikum warahmatullahi wabarakatuh and very good afternoon. Yeah, thank you so much to Farina personally for inviting me, to the sharing session, and then to MAPD for, as organizer for this ataupun this call sharing session. I will start sharing my slide, but one thing that hopefully, you can start seeing the slide now. Okay, the topic that was discussed between me and Farina, when she approached me back in February or January, was COVID-19 in children. Okay, at that particular time, it seems to be significant, very relevant, because it was at that time the COVID-19 cases among children had increased, and of course at the government as well, at the time point where we were talking about starting the COVID-19 vaccination among children. because of and that topic were decided then. Of course, things had changed so much since February or March when March, I guess, when we actually selected the title. And now, because we already moved from the pandemic and the worry about this, even the COVID-19 vaccination program, much children had been so-called campaign had been completed. So people will ask me why are we still talking about COVID-19 when we are already nearly saying goodbye to it? But actually, it's not. We are not really saying goodbye to it. In fact, we are now living with COVID-19. Yeah, and this possibly, I will not talk too much about things that we're going to know. I'm not going to talk about the viruses. I'm not going to talk about it, but I'm going to talk about main thing that what we learned from COVID-19 in children, and what are the main point and learning points that we can learn from it. So hopefully, these could be points that we can share among the community, among our colleagues, and that's as dental colleagues of ours, we know that when we actually talk about COVID-19, what will be the flow of thoughts that the pediatrician, the clinician need to talk about or think about. Yeah. So I think one of the main questions that a lot of people ask me, especially when things happen, does children at high risk of COVID-19 infection? Just to be on the safe side, yes, children is less affected by COVID-19. That's the truth. If people want to say, some of the pediatricians want to say, COVID-19 do happen among children. Yes, it does happen among children. Nonetheless, the numbers kind of tell us that the cases are, when we actually look at Malaysia data between 23rd August 2021 to 3rd of February 2022, only 10% of all the COVID-19 cases in Malaysia were inflicted children between the age of 5 to 11 years old. And most of the cases, they are mild or asymptomatic. Nonetheless, it cannot be kind of comfortable because what we know is that 174 children between the period of June 2020 to December 2021, about 174 children below 18 years old suffer from what we call the multi-systemic inflammatory syndrome. Yes, the number is not too much, but most of these patients require ICU care. And about 26 deaths resulted during that period of time from these 174 children resulted to death due to what we call MIS-C. So the numbers might not be high, the numbers might not be, as severe as what we thought in adults, but this is a significant number because there are children, there are those populations who eventually, if they have infections, they have mild, but within that mild 10% of COVID-19 cases, some of them do suffer what we call multi-systemic inflammatory syndrome in children, or we call as MIS-C. Kind of a recap, some of you possibly heard about it. What is what we call this multi-systemic inflammatory syndrome in children, or MIS-C? It's one of the sequelae of COVID-19 infection among children. So when we say sequelae, it means that usually happens after the so-called initial infection. Yes, some of them actually happen concurrently. They have the acute infection and just 1 or 2 weeks, or in fact, when yet to fully recover, they start to develop the symptom. But most of the cases of MIS-C happen about a month after the initial infection. And the features of the so-called multi-system or MIS-C is they have fever, and with more than one of the following. Either they have stomach pain, diarrhea, vomiting, skin rash, red eyes, and dizziness of lightheadedness. And if you look at these symptoms are very vague. They are, common symptoms that happen. People not really think about MIS-C, or people not really think about COVID infection because we are talking about diarrhea and vomiting, which is a common symptom among children. And the problem is that when we initially have it, when people don't really know about MIS-C, we even have to include a screening for COVID-19 among patients who presented with so-called acute gastroenteritis symptom. So one of the criteria when we actually look at our whole protocol when we went to the COVID-19, when we screened nearly everybody, we actually put patients with AGA symptoms in our SARI ward because these are the features of COVID-19 infection among children. But why are we so worried about MIS-C? It's because other than the fever, it actually have more features that, more clinical presentation that affect a lot of other systems, and some of them can be fatal. It is commonly cause a problem into the cardiac dysfunction. Some of them, one of the common features of MIS-C is that during the fever itself, they tend to have a lowish kind of BP. They tend to be a bit more tachycardic. They tend to have a bit more high heart rate, and then the BP tend to be just holding on a normal low percentile. And they progress so rapidly. If people are not looking for it, people are not thinking about MIS-C, the patient can lead to a serious manifestation. And I think during our experience in HUKM before, and of course now less because we have moved over to HPK, we do see 1 or 2 cases, but now we are much better. But I think when we have a patient who have fever, prolonged fever, and then their history of family members have MIS-C about a month ago, we always kind of think about MIS-C, and true enough, about 80% of the cases turn out to be MIS-C. And what really, as you can see from the manifestation here, they can have macrophage activation syndromes that can lead to a lot of other sequelae and a lot of the problems. Some of them can even have seizures due to neurological involvement. Some of them can have respiratory failure requiring ventilations. We do have one case that unfortunately presented initially, was missed as MIS-C, was not treated as MIS-C, eventually come to us at a very fatal stage, died because of the kidney involvement. The patient actually had acute kidney failure, the lung just collapsed, the heart just failed, and despite what we actually have done, despite the treatment that we've given, it's a bit too late. So we are worried because of this, if not being identified early, can actually lead to death. And initially, people kind of confused this with Kawasaki disease. In fact, the initial name of the so-called MIS-C was Kawasaki-like disease. I think now this is not true anymore. We should actually clearly differentiate between Kawasaki disease and MIS-C, because the cause of the disease and the progress and the underlying pathogenesis of it are very different. Yeah, and in fact, because of the difference between Kawasaki disease and MIS-C, one of the way that a lot of people now actually always kind of think about MIS-C and forgetting about what Kawasaki disease is, because the Kawasaki disease in fact can actually have a similar manifestation. So we were being called to kind of like do a review, a systemic review about the clinical manifestation and all the laboratory finding of Kawasaki disease beyond the classic diagnostic features, kind of like reinforce and differentiate between Kawasaki disease and MIS-C. Because subsequently, you know that the modalities of treatment between MIS-C and Kawasaki disease, they are different between those two entities. The mainstay of treatment when it comes to Kawasaki to MIS-C is IVIG, which we actually use in Kawasaki disease. And in fact, in the New England Journal of Medicine, where they are published this in fact in 2021, they show that the use of IVIG or IVIG we call glucocorticoids or glucocorticoid alone do not have show any significant difference between the requirement of immunotherapy support or ventilatory support. Nonetheless, from our local experience, from my personal experience, the requirement of glucocorticoid as an adjunct therapy are very much dependent on how fast and how severe and how multiple system, how many systems are affected, and how bad was this inflammation. And in fact, that is a new research study that was published in late December 2021 that showed the dual therapy using infliximab, which is a monoclonal antibody against anti-TNF alpha with IVIG, shown to actually have a better outcome, not just in terms of the hospital stay or the ICU stay, but it actually leads for a lesser requirement of additional immunomodulatory therapy. The anti-inflammatory responses are also much better, and I believe that now they have a subsequent follow-up to show that those patients actually have a lesser sequelae compared to patients who actually have IVIG alone. So the reason why we need to differentiate between Kawasaki disease and MIS-C is because the treatment of Kawasaki disease, other than the IVIG, include the requirement or the starting of aspirin, high dose aspirin, which can cause a significant problem if this is due to non-Kawasaki. Yeah, so that's the reason why it is important to differentiate between these two entities and then to have the right modalities of treatment. So MIS-C is one of the complications that is very true, happen in children, and something that we need to look for. And what really interesting about MIS-C is that MIS-C is severe. The initial infection of COVID-19, in most of the cases of MIS-C, sometimes is not even severe at all. Most of the patients who are diagnosed to have MIS-C in our center, about 80% of them, their first or their actual COVID-19 infection were asymptomatic. About half of them were not even diagnosed. They just have family members who are positive, and their initial RT-PCR or their initial so-called RTK were negative. But eventually, we have the evidence of they were affected because they have a positive serology test. So they can happen in the patient who do not have a significant COVID-19 infection, but the sequelae can be bad, can be actually leads to the development of MIS-C. Another thing that we are now learning about so-called COVID-19 is the long COVID among children and adolescents. Some of you possibly heard about this, especially among adults. People are talking about the sequelae of the long COVID among adults. But as more children and adolescents are affected, we realize that this long COVID manifestation do occur among children and adolescents. In fact, there is a global movement to kind of like highlighting that the long COVID among children is actually a true entity and not just something that, the child just creates these symptoms. And as you can see, the symptoms that they complain are broad, brain fog, visible vein, mood swings, depression. Some of them, like in this girl, Tilly's COVID journey, she had problem with nausea and loss of appetite, requiring her, despite month 6 or month 7 after the initial infection, to be fed with rice. Yeah? So long COVID is true, and what really we don't yet understand about long COVID is the broad signs and symptoms that affect these so-called patients with COVID. And among children and adolescents, 25% of patients who actually have COVID infection have the so-called long COVID symptoms. So about a quarter of them will have this long COVID symptom. It is understandable if you're talking about respiratory symptoms, which about 7%, 8% of these so-called patients who have long COVID actually complain about respiratory symptoms. That is understandable from the perspective of the clinician, because we're talking about, coronavirus or SARS-CoV-2 being respiratory viruses. So the effect to the lung leads for them to actually have respiratory symptoms, the sputum and nasal congestion. That is fair. But what perplexes us about the long COVID is how the effect on the neuropsychiatric or even the dermatological manifestation. In fact, the mood swing, the fatigueness, the sleep disorder are quite a significant long COVID sequelae or long COVID manifestation among children and adolescents. And people might, miss it. People might just say, oh, he tends to be, my child tends to be difficult. He now have a mood swing, or this is just a period of time. But there are a good, what we call the systematic reviews and meta-analysis being done now to show that this neuropsychiatric manifestation is true and is a due result of this so-called long COVID manifestation. So what needs to be done? Any person who actually has symptoms 3 or more weeks after COVID-19 onset, a good thorough clinical assessment, including history, examinations, clinical examination, and some investigation are possibly required. And one of the most important things I would like to emphasize is that the mental health, the psychological assessment is as important as the organic or the clinical manifestation. Yeah? And the management of this lung COVID should emphasize not just on the clinical management, into all the symptomatic, talking about treating the comorbidities, looking after in terms of the worsening breathlessness, what we all thought initially the long COVID manifestation, but now we, especially the pediatricians, especially the clinicians, we now know that the long COVID also involves other manifestations, being sleep, being having problem to sleep, being agitated. So listening, having empathy, and trying to consider that complaint are true are very much what needs to be done in all patients who actually just recover or had the COVID infection itself. And the management have to include, as I mentioned, mental health, but any kind of modification in terms of diet, the sleep, sleep hygiene. If they have problem, we need to entertain that. We should not just leave it. And for adults, in fact, it is important for adults to quit smoking among children, to limit their alcohol intake, because and among children itself, among adolescents, need to limit their caffeine intake, because these possibly have a ripple to the management in terms of the lung COVID manifestation. So as we are talking about the MIS-C, we are talking about the lung COVID manifestation among children due to this COVID-19 infection. Yes, one main thing that we want to focus about, can we prevent COVID-19 infection among children? And I guess we are, being in the health management environment, we are very much aware about the hygiene. We are very much aware about the transmission of this so-called SARS-CoV-2 viruses. And one of the things that we know are able to prevent COVID-19 infection that have been proven to actually do that is COVID-19 vaccine. I'm not going to talk about COVID-19, the different type of COVID-19 vaccine or the data or the safety profile, because most of you are aware of it. But I'm going to focus on one thing that is very true when it comes to COVID-19 vaccine with interest to children and adolescents. And we are talking about the COVID-19 vaccines and the side effect of myocarditis. Yes, most of you are very much aware that myocarditis, as the name suggests, is the inflammation of the heart muscles. And this can happen after any viral infection, they call viral myocarditis, and this also includes COVID-19 infection. But one thing that we are talking about this is because it can also happen after receiving mRNA COVID-19 vaccine. They actually shown that those children or those adolescents who actually have myocarditis following the vaccine delivery, 99 or 98.7% are due to related to mRNA vaccines. Okay, but one thing as healthcare professionals, we need to know that if you are unvaccinated, risk of having myocarditis from the COVID-19 infection itself is very high. It's 4 to 8 times higher risk compared to the patients who are vaccinated. Okay, and most importantly, the reason why they are vaccinated is we want to prevent the sequelae or the risk of having hospitalized due to the COVID-19 infection. But coming back to if you are vaccinated with COVID-19 vaccine, the risk of having myocarditis is actually 1 in 200,000 doses. And the risk is much higher with the second dose, okay, or the booster dose. Males, young males between the age of 12, and particularly between the age of 12 to 17, they have a slightly higher risk compared to any other population, especially females and the older ones and the younger, much younger ones. So by itself, these are the population who we are a bit more, the observation need to be done. Nonetheless, among those males who develop the myocarditis, most of them have mild symptoms of myocarditis, and most of them are self-limiting. They recover without any treatment required. Okay, so saying that the risk is there, but the risk is low. Even if they develop it, the symptom is mild. They usually recover without much of the treatment. And I think we need to understand the risk, and of course we need to understand as well, or to know what the advantages, so that people can make a more holistic kind of a more what we call appropriate decision, rather than just blindly either taking it without knowing the side effect, or more importantly putting the side effect as a block for these parents or yourself as a parent, or yourself as family members, for your children to actually receive the COVID-19 vaccine. Because up till now, at the current time that we're actually talking about, the only primary prevention of COVID-19 vaccine, other than hygiene and lockdown and such, is through COVID-19 vaccines. Okay, we do not have a good what we call treatment or secondary treatment yet for COVID-19 infections, especially among children. We do now have a monoclonal antibodies for post-exposure or preventing patients who are at risk of developing serious COVID-19 infection when they are exposed. I'm not sure if some of you are aware that the Malaysian government actually have bring in a monoclonal antibody, a SARS-CoV-2 specific monoclonal antibodies to be given for the immunocompromised patient. Okay, and it has shown that these monoclonal antibodies were able to protect them against COVID-19 infection with one doses delivery of this monoclonal antibody. It comes into injection because there are different monoclonal antibodies given at the same time. They can protect the so-called immunocompromised population for a period of up to 6 months. Okay, this can only be given to patients who are 12 years old and above at this current time. Okay, so again, other than the vaccine, for children below than 12 years old, there is no modalities for prevention of this COVID-19 infection among the population. Okay, as we are talking about one MIS-C, we talk about long COVID. Also talk about prevention through vaccines. We also need to understand the ripples of COVID-19 disease beyond the individual who are affected. We are not talking about those who are having COVID-19 infection, but the COVID-19 disease as the disease itself in a general population, and how it affects the children. And this is a nice study done by a Canadian government or Canadian Ministry of Health. And what they actually look at is the parents and the family anxiety and what they are concerned about their children. And these are very true. 71% of parents and the families feel the concern about the opportunities for the children to socialize with friends. Children are born to socialize. They interact, they learn through interactions. And we've seen a lot of cases over the last 2 years, children referred to our clinic for speech delay. And the reason for speech delay are very much true because there are lack of interaction, very lot of screen time, and no peers-to-peers kind of interaction, no school, and these are the concern of parents and families about it. Amount of screen time, loneliness and isolation. We do have cases of 11-year-old boy who turned out to be depressed because of the lockdown period, and we thought that it will be adults who are affected by it, but children do feel loneliness and isolation, and depression do occur in children at the same time. Yeah? And of course, you also know how the lockdown, how COVID-19 actually caused lockdown and caused effect to the school years and academic success. A number of people, I remember that my own nephews actually sit for SPM recently, and one of his colleagues not able to sit for exam because infected because of that, and they at that particular time do not know that there will be an additional exam. Luckily, the government actually decided to have that for those who are infected. But imagine, the trauma of having to repeat another year if that actually happened. How that would affect the child mentally and psychologically. And of course, it's not just affect their concern about children, but the effect of this COVID-19 actually happens to the families and to the parents itself. How do you want to balance childcare, schooling, and work? When your children actually infected or infected by COVID-19, you need to be quarantined for 7 days. Yes, the children need to be quarantined, but how that affects you? And this actually have a ripples. That ripples is true. And of course, during the lockdown, there were a lot of parents come to me. Initially, they were happy, during the first lockdown, they were happy. They said, oh, I'm healthier, I'm more close to my children. Because at that particular time, all of them, everybody was locked down. So everybody had to be in their family. When things are in moderation, people are okay, they get along well. But something else happened during the second lockdown. Parents now getting more agitated. One of my patients who are doing the first visit because of obesity, suddenly they're able to cut down the weight because they are eating healthier, they do more exercise during the first lockdown. A year after that, the second lockdown, we didn't see we are not just seeing what we call there's no improvement in terms of weight, but the child starts to gain weight again because now the parents need to work, the child is at home, there's more access to food, somehow there's no time for the child, and then things start to go in a different direction. And it's quite interesting how COVID-19, the initial stage can cause some sort of like harmonious coexistence, and how the second lockdown or the third lockdown actually caused a disastrous impact to all of us. People tend to be on the social media, also tend to be, start scolding, start throwing things and not believing us, the healthcare professionals, before that, people were joining hands together trying to prevent COVID-19. And I think one of those reasons because there is a desire of all of us to go out from the so-called pandemic. And very much true when the government decided that we are moving over to endemic phase. A lot of people actually are happier, but a lot of people are still concerned about what the risk is. And actually that question is not new. In fact, this has been the question that a lot of immunologists particularly had been asked. And in fact, Nature, I think this publication was back in 2021, asked 190 immunologists, infectious disease researchers, and virologists from 20 countries, asking one very important question. How likely do they think that SARS-CoV-2 will become an endemic virus, which is one that continues to circulate in the pockets of global population? Even at that particular time, the scientists, 89% of them already thought that we will not able to eradicate SARS-CoV-2. We will have to live with SARS-CoV-2. And when they ask a very more specific question, will some region or some country able to eliminate SARS-CoV-2 with their so-called very intensive vaccination, herd immunity, something like what New Zealand is trying to achieve, or Israel was trying to achieve? Only about 39% of them felt that there is a likeliness for that to happen. Most of the scientists and immunologists were thinking that no, this virus will possibly going to be with us for a long time. And among the driving factors that they thought why that would be true is because, as we know now, the virus itself, when we first start making our vaccine, people were so happy. Oh, okay, we can protect against the alpha and the beta strain, and then suddenly Delta come. And then we are thinking about, some of the vaccine companies say, okay, my vaccines are protected 98% or 95% protecting, have protections against Delta variant. We were then pushed into a corner when suddenly Omicron come about, and we know that the efficacy of so-called the vaccines are not as good as it protects against some sort of transmission, it protects about it, but the prevention are not as great. One of the statistics now, I'm just recovered from COVID-19. I'm less than 10 days from it. I vaccinated for 3 doses, and true enough, waning the immunity are very much possibly the reason why it affected me. Because we instill the same kind of what we call practices. I'm still wearing masks outside. Just that my sister, who is also a doctor, exposed to it, received the vaccination, 3 doses booster, and it just finally 7-8 months after the 3rd booster, the protection is not there. So waning immunity are true, this cannot be denied. This is why the booster is required. Uneven vaccine distribution, hopefully this is not the case in Malaysia, but this is very much true in some part of the world. Vaccine hesitancy, a case what happened in Malaysia, especially among the children, people are worried about it. Hopefully there is no lack of political will, because other causes are animal, rosacea, and others. Final question, this is my last slide for today. Will COVID-19 here to stay? And I think this is again another kind of a nice flow chart, nice kind of algorithm for you to kind of reason out yourself. Is this going to stay? Are we going to indicate things? How the direction is? And this is true for a lot of other infectious diseases. And the first question you ask is, does immunity from the vaccine or the infection wane? And we know now, yes, it is. That's why the booster is needed. Can the vaccine block transmission? Yes, when they are effectively and the immunity is not waning. Is the vaccine coverage wide enough to reach herd immunity? If the answer is yes, which is what people are trying to achieve in some of those initial stage of strategy where they want to eradicate or eliminate SARS-CoV-2, then it will be like measles. The virus will be eliminated in some region that reach the herd immunity, where the vaccination rate is lesser, then there is always going to be a breakthrough. But if the answer is no, we are not able to reach herd immunity, this is when it becomes an endemic. Yeah, when the virus will continue to circulate, but once more people are protected, they are protected from severe illnesses. So that's why we now hear a lot more people who are positive, but they only have mild to moderate disease. This COVID-19, this SARS-CoV-2 now is actually becoming one of the flu viruses, if we may. But we are worried if they start to become the virus that evolved to escape the immune system, they mutated, and then they become again another Delta type where we are not protected in our vaccine. And if that happens, the new vaccine or new modalities need to be reformulated regularly, and that's what now the immunologists are doing. They are trying to develop as much as mRNA, try to see what are the possible mutations that happen so that we will come up with a vaccine, and if that happens, that will require. So we are still learning. As far as we know now, the likeliness of COVID-19 will possibly stay with us. That's what we are right now. Unfortunately, that's the reality. And when it comes to children, I highlighted a few important points. Myths here are very true. It's severe, it can cause death. Long COVID are very true. Not just respiratory symptoms, we see a lot more. Vaccines are effective. Nonetheless, there are limitations, not just because of the waning immunity. There are some related side effects, but as far as we know, it is mild. And the endemic entity of what we call COVID-19, there always a possibility that the so-called endemic will become pandemic. The pandemic will become endemic again, and hopefully, eventually we're able to eradicate from the algorithm that we just did. The likeliness is very less. So with that, I thank you all, and I'm welcome for any interactions or any questions.
Okay. Thank you so much, Dr. Adli, for the session. Yeah, like Adli was saying earlier, where we decided this topic is a very hot topic, but now more on reinforcing the importance of prevention and also educating others about the importance of vaccines, especially for children. Okay, if anyone have some questions, please post in the chat box. I can read, or if they have any questions directly to Dr. Adli, you can welcome to us. He's very happy and looking forward to help with it. Okay, maybe I can just see whether we have any questions in the chat box. Okay, all right. Okay, we have, sorry. I think this is Dr. Joanna, our president of Malaysia Association. I think she has some questions for you.
Okay, hi, Dr. Joanna.
Hi, Dr. Adli. Thank you for an excellent presentation. I actually requested Farina to have this topic on COVID-19 in children. So naturally, I have some questions. Now, we are talking about going into the endemic, and children above 5 having vaccinations. What about children below 5? Are we going to see pockets of COVID-19 in this group of children that are vaccinated? Thank you.
Yes, definitely. We are seeing that now. In fact, most of our COVID-19 now is actually affecting this younger population. At least what we are seeing admitted lah, because population-wise, unfortunately, it's a bit hard. You know, I'm working the hospital level, so I know in the population-wise there are a lot more people who are affected. Yeah, but just talking about the experience, about our experience, about my family experience when we are infected with COVID-19. So some person touched that those who are vaccinated, despite that they are living together as a family, and I am the outstander because I actually the uncle, yeah, and we are not living in the same house. Those who are vaccinated earlier and their booster was waning, they are not protected. But the one who actually, you know, the one who are the adolescent who just received that vaccination, somehow they were protected. And of course, another beautiful thing was that I was working and my nephew was admitted on a day before I was diagnosed. I was somehow the consultant as well, and I reviewing, and as become an uncle, I review, I pakai mask semua, I masuk balik bilik tu, and I was holding this so-called 3-4 months old, going to 5 years old, 4 months old boy, and then, you know, without wearing a mask, because I don't know yet that was my sister that actually will be positive. The next day, actually, I turned out to be positive with all the symptoms. Okay, we were so worried. The clinician here decided that, okay, they need now my nephew, because of me, the culprit, become a PY. But the beautiful thing about vaccination, that the mother's immunity can actually live, and this boy will breastfeed. So we were worried so much, and we were thinking, why am I so close? And was not wearing it. I was holding the baby for a period of time, and the child was really playing, and you know, like baby, kind of playing, touching my mouth and things like that, and then putting the face, the period of time 5 months old. And he did the RT-PCR day 3 and day 5, and he did not have the symptom. A boy, my nephew are going to 3 years old, infected by that. 5 years old, who actually was 5 years and above, who actually exposed, none of it actually turned out to be positive. So what I could basically relate to this, waning of immunity happened, pockets of the so-called infection are now going towards this younger population who are not protected. Breastfeeding is good. If you have the immunity, some of it are being delivered to you, especially because IgA is what kind of like antibody that we really felt that is important in terms of protection against respiratory, and IgA is being delivered by breast milk to the babies, you know. So I think that's beautiful. Yes, to answer your question, we are seeing the pockets of it. The good thing about it is that they are the population who are mild. They are the one who, when they develop symptoms, they are mild. But taking into account that, I have one patient who actually we are treating for vegetative adenitis, admitted because it was ruptured. somehow when we did the RTK, turned out to be positive. No respiratory symptoms. We admit because we want to give antibiotic for so-called the BCG lymphadengitis. 2 months along the way, following that so-called period of time, we do not have any respiratory symptoms, no cough, nothing, no fever. In fact, was just some discharge from the lesion. But following that, 2 weeks after that, patients start to have cough, and the cough persists 2 months along the way. And we just did an X-ray because we were worried now if this BCG lymphadengitis turned out to be T. And true enough, there are changes which was not there when we worked out the first patient. We are not able to answer if this part of long COVID. We are not able to answer was this actually due to COVID, but the actual episode itself when he was having infection, we have no cough. So now we definitely know this is long COVID, but we are not sure why the patient do not manifest any respiratory symptoms during the actual infection and only happen, a month after that. So yes, the infection might be mild, but the long COVID can actually cause more problems. We are seeing this now. We are seeing a lot of patients who basically become asthmatic-like following the so-called infection who are not even very bad. So it's a bit worrying because we don't really know. Should we treat them as asthma? Starting inhale corticosteroid as such. So the long COVID itself, the Joanna, will possibly were more problem to us rather than infection. Yeah.
Yeah. Thank you very much for the extensive explanation, Prof. Pass over to Farina again.
Is there any more questions from the participants? Okay, dalam chat box tak ada lagi. By the way, just to tell Dr. Adli, from the chat box, people are very happy. Thank you for the sharing and others. I think that's about it. I think no more questions. Maybe Dr. Adli, any last words from to the MAPDs?
Ada Anak Puni.
Sorry, angkat tangan. Okay. Yes, hello.
Hi.
Sorry, this is our Vice President Adli.
Hi.
Just wanted to share some thank you for the talk. It was very good and personally for me as well because my son had MISC and at the point when he had it, no one really knew about it. So it was really quite a bad experience. But luckily, I was lucky enough because I was attended to by Dr. Anis and her team at Selayan. So it definitely, just to add on to what you said that, he was completely asymptomatic and nobody knew. Actually, no one at home tested positive. And when we were in the hospital, the other children who had come in were all those who had 0 symptoms. Other family members who had symptoms seemed to be okay, but the ones who didn't. So after that, I have been advocating to people, saying that if your child had COVID and no symptoms, please look out for, especially that window of 1 to 2 months. And I think it's so important. And but the only sad part is not many people, not many parents out there actually believe that MISC exists. And I was asked to actually share my testimonial and experience, and even with that, some people actually responded to the video saying, "Oh, this one must be a fake story. It's just an acting or something like that." So I think there's a lot of work for us to do out there to advocate and make sort of bring about that awareness. So that just wanted to share my side of the. And definitely thank you for highlighting the long COVID. For us as dentists, we need to be asking. That means now everybody who comes in, we have to ask, has the child had COVID? Mark it down, and we may be picking up some of the symptoms and things like that. Thank you so much.
Yeah, thank you so much. I believe that is true because somehow we were doing this study looking at the effect of menstruations disturbance among those who received vaccine. And as well as nasal symptoms. And I believe that, among you all will actually have that, possibly, I don't know what are the dental, some neuralgia or that kind of, any kind of pain or any caries that might be, associated with it. We don't know until we actually look for and ask this question. Thank you so much for sharing, and I'm glad that your son recovered and was diagnosed. Because during the early times, I think you're very unaware, don't really understand MISI as much, and we learned a lot from our patients. So and hopefully now we have a better management for our patients when they are infected with MISI or long COVID. Thank you.
Thank you.
Okay, I think thank you, Dr. Adli and Dr. Anna for sharing about me. I think that's the time that we have for today. For all the participants, we have put up the link for the CPD points in the chat box. Please do click the link. And for from MAPD, we are very grateful for Professor Dr. Adli to share his sessions on COVID-19 in children. And with that, thank you so much, and hope another topic, any other time for immunodeficiencies. Okay, thank you everyone, and have a nice afternoon.
Okay.
Okay.